I want you to take a deep breath right now. Just hold it for a second.
And then just let it out.
Yeah, let it out. It's this incredibly complex, highly synchronized, and, well, mostly automatic process.
Right, which we completely ignore.
Oh, totally. We completely ignore it right up until the exact moment it fails. So today we're doing a deep dive into the textbook Respiratory Medicine clinical cases uncovered by Emma Baker and Dilys Lai.
It's a fantastic resource.
It really is. And our mission today is to serve as an educational journey for, medical students, young professionals, or just curious self-learners out there. We want to find out exactly how this invisible machinery works.
How doctors basically act like detectives when that machinery breaks.
Exactly. And what's actually happening in your chest when you cough or wheeze.
Breathing really is like the ultimate background application running on the body's operating system.
That's a great way to put it.
Yeah, I mean, you take thousands of breaths a day without a second thought. But the sheer anatomical and physiological machinery required to make just that single breath happen, it's staggering.
So we're going to break down the basic science, translate the clinical assessments, and then we're going to drop right into the emergency room with real-world cases.
Things like asthma, COPD, and pulmonary embolisms.
So to build this from the ground up, let's trace the actual anatomy of a breath, because it doesn't even start in the lungs, does it?
No, not at all.
It's really a physiological chain of command.
Right. It starts in the brain. The respiratory center up in the brainstem fires off an electrical signal.
Okay.
And that impulse travels down the spinal cord, out through the phrenic and intercostal nerves, and it basically tells your respiratory muscles to fire.
So the diaphragm drops down.
Exactly. The
Okay.
diaphragm drops, the muscles between your ribs pull outward. That expands your chest cavity and creates a literal vacuum.
Wow.
Yeah, and then atmospheric pressure just forces air right into your face.
And that air slams into the upper airways first, right? Like the nose, the pharynx, the larynx. But this isn't just a simple hollow pipe. The upper airway is doing a massive amount of prep work before that air ever even sees a lung.
Oh, absolutely. Think of the upper airway as this heavy-duty HVAC conditioning system.
Okay, an HVAC system.
Yeah. As air enters the nasal cavity, it passes over these structures called turbinates.
Turbinates.
Right. They're these fleshy, ridged shelves with a massive blood supply. They act like radiators, instantly warming the incoming air to body temperature.
Because cold air would be bad.
It would be terrible. They also humidify it. If you pulled dry, cold winter air directly into the delicate, deep lungs, it would just completely damage the tissue.
Ouch. Yeah, that makes sense.
So from there, the warmed, wet air drops past the epiglottis down into the trachea, and that's where the branching begins.
Right. The trachea splits into the right and left main bronchi.
Uh-huh.
And then it just keeps dividing, right? Like the roots of a tree.
Exactly like a tree.
The book mentioned something like 25 separate divisions of bronchi and bronchioles before you reach the end of the line.
And the end of the line being the alveoli.
Right.
You have around 300 million of these tiny microscopic air sacs in your chest.
300 million.
Yeah. If you flatten them all out, their surface area would cover roughly the size of a tennis court.
That's just mind-blowing.
Yeah.
Inside your chest.
It is. And
Yeah.
this massive surface is where the actual magic of gas exchange happens. It's where oxygen diffuses into the bloodstream and carbon dioxide is, pulled out.
But to understand how fragile this system is, you have to look at the cells building those alveolar walls,
Yeah.
right? The pneumocytes.
Yes, the pneumocyte.
And the book highlights a massive difference between the two types of cells down there. Type I pneumocytes make up over 90% of that tennis court surface area.
About 90 to 95%, yeah.
And they're described as having extremely thin cytoplasm. So they are essentially the microscopic, like paper-thin drywall separating the air from your blood vessels.
Yep. That extreme thinness is non-negotiable. Gases have to cross that barrier instantly.
Right.
If those cells were thick, you'd literally suffocate even while breathing heavily. But there's a mechanical problem with having 300 million tiny wet sacs in your chest.
Because water molecules like to stick together.
Exactly. The fluid lining the inside of those alveoli creates surface tension.
Which naturally wants to pull the walls inward and basically collapse the little balloon.
Yeah.
I always think of this like, imagine you have a completely wet balloon and you're trying to blow it up. The water inside makes the rubber sides stick super tightly together.
That's a great visual.
It takes a huge amount of force to rip those wet sides apart with just your breath. But if you were to apply like a thin layer of soup to the inside of that wet balloon, The sides would slide apart easily.
Precisely.
That's where the type 2 pneumocytes come in, right? They're the soap dispensers.
That is a brilliant way to visualize it. Type 2 pneumocytes produce this lipid protein cocktail called surfactant.
Surfactant. Okay.
Surfactant coats the inner lining of the alveolus and just shatters that surface tension. It physically prevents the alveoli from collapsing flat at the end of an exhalation.
Because if they collapsed.
Without surfactant, the mechanical muscular effort required for you to pry open 300 million collapsed wet balloons for every single breath, it would exhaust your respiratory muscles in minutes.
Wow. Okay, let's unpack this setup.
Yeah.
You've got a tennis court's worth of incredibly delicate, microscopic, soap-lined balloons inside you, with blood rushing just millimeters away.
Very fragile.
Right. But you are constantly breathing in dust, exhaust fumes, bacteria, fungal spores. How does this massive, fragile surface not get instantly infected by the barrage of foreign garbage we inhale every minute?
Well, the respiratory system relies on a mechanical defense called the mucociliary escalator.
The mucociliary escalator.
Yeah. Throughout your larger airways, the cellular lining is carpeted with cilia, or these tiny hair-like projections.
Okay.
And interspersed among them are goblet cells, which do exactly what they sound like. They secrete goblets of sticky mucus.
So the mucus acts like flypaper, basically trapping inhaled particles and pathogens.
Exactly. And the cilia are the moving stairs of the escalator.
Ah, I see.
They beat in a highly coordinated upward motion about 1,000 times a minute.
1,000 times a minute?
Yeah, it's fast. They constantly sweep that contaminated mucus layer up and out of the deep lungs, back up the trachea toward the throat.
Where you either cough it out or swallow it down into the stomach acid.
Right.
But obviously some things get past. The really tiny particulate matter, or I don't know, an aggressive bacterium, slips by the flypaper and makes it all the way down to those delicate type I pneumocytes.
And when the mechanical barrier fails, the biological infantry steps in, specifically the alveolar macrophages.
Macrophages.
Yeah, these are the immune system's roaming garbage trucks. They patrol the alveolar spaces on the hunt.
Okay.
When they bump into a foreign particle or a bacterium, they perform a process called phagocytosis.
Which literally translates to cell eating.
Exactly. They physically swallow the invader whole.
That's wild.
It is. Once the bacteria is trapped inside the macrophage, the cell bombards it with destructive acid and enzymes from its lysosomes, dissolving the threat completely.
So we have these incredible defenses, the mucus, the escalator, the cellular garbage trucks. But what happens when the invader's too aggressive?
Well, that's when the body responds with inflammation.
Right, and the book outlines the 5 classic signs of acute inflammation using these ancient Latin terms, which sounds like something out of a medieval medical text, honestly.
It really does.
We've got rubor, which is redness, calor for heat, dolor for pain, tumor for swelling, and latio functae, which is loss of function.
It sounds archaic, I know, but the physiology hasn't changed. What's fascinating here is how those ancient Latin concepts translate directly to modern respiratory symptoms.
Like how?
Take tumor or swelling. If a bacterial infection causes inflammation deep inside the lung parenchyma, that tissue swells up and fills with immune cells and fluid. Clinically, when a doctor listens to that area with a stethoscope, they hear reduced air entry. The swelling has literally choked off the space.
Wow. And what about dolor? Pain. Because we know the spongy lung tissue itself doesn't actually have pain receptors, right?
Correct.
Like you can't feel a lung infection the way you feel a cut on your finger.
The lung tissue doesn't, but the pleura does.
The pleura.
Yeah, the pleura is the double-layered membrane wrapping around the lungs. If that deep inflammation spreads outward and irritates the pleura, that dolor presents as pleuritic chest pain.
Ouch!
Yeah, it's this intensely sharp, localized stabbing pain that gets dramatically worse when you take a deep breath or cough. Imagine 2 pieces of inflamed sandpaper rubbing against each other every time your chest expands.
That sounds miserable.
Yeah.
So if a patient comes in with that pain, or just generally complaining of breathlessness, how do we quantify that? I feel short of breath is incredibly subjective.
Very subjective.
Right? One person's breathlessness is another person's mild jog.
Exactly. So clinicians use standardized tools like the Medical Research Council, or MRC, dyspnea score.
The MRC score.
It's a highly practical 1 to 5 scale used to anchor that subjective feeling to real-world limitations.
Okay, how does the scale work?
Grade 1 is breathlessness only on strenuous exercise. Grade 3 means you have to stop for breath when walking at your own pace on flat ground.
That's a big jump.
It is. And it progresses to grade 5, meaning the patient is completely housebound or becomes breathless just trying to put on a shirt. It establishes a hard baseline to track if a disease is progressing.
And tracking disease means moving into the physical exam. The sources list exactly what a clinician looks for, well before they ever touch a stethoscope.
Observation is key.
They check the hands for nicotine-stained fingers. They look for cyanosis, that bluish-grayish discoloration of the lips or fingertips.
Which is basically a flashing warning light for hypoxia, meaning the hemoglobin in the blood is starving for oxygen.
Right. But they also measure something called the percosternal distance. That's the gap between the cartilage in your neck and the top of your breastbone. Why are we measuring the neck for a lung problem?
It's a beautiful example of anatomical cause and effect. Normally, that gap in the neck is about 3 to 4 finger breadths wide.
Okay.
But in severe obstructive diseases like COPD, the lungs lose their elasticity and become massively hyperinflated.
They just get too big.
Yeah, they trap air and permanently balloon outward. This huge hyperinflated chest physically pushes the diaphragm down into the abdomen and pulls the trachea downward from the neck.
Oh, wow.
So that cricosternal distance shrinks to just 1 or 2 finger breadths. You can visually see the structural distortion of the lungs just by looking at the patient's throat.
Wait, hold on. I need to challenge one part of this clinical assessment.
Okay, go for it.
The textbook heavily outlines percussion. You have the doctor placing a hand on the patient's back and tapping their fingers. We live in an era of high-resolution CT scans that can spot a millimeter-wide shadow.
We do.
Why is a modern doctor still thumping on a patient's back like they're checking to see if a piece of drywall is hollow?
Because imaging requires moving a sick patient down the hall, waiting for a technician, and then waiting for a radiologist's report.
That takes time.
Right. Clinical signs give you data in 3 seconds right at the bedside. Percussion is essentially an acoustic density test.
Okay, an acoustic density test.
If you tap over normal, healthy lung, it sounds resonant like a low-pitched drum. But if you tap and hear a flat, dull thud, it means the air underneath has been replaced by something dense, like a pool of fluid from an effusion or a solid mass of infection from pneumonia.
I see.
Conversely, if it sounds hyper-resonant like too hollow, it points toward a collapsed lung where air has escaped the tissue and is trapped in the chest cavity.
Okay, instant bedside feedback. That makes total sense.
It's incredibly useful.
So let's take all this basic science, the anatomy, the inflammation, and bring it into the emergency room. Let's look at obstructive airways disease.
Case 4 in the book.
Right. Case 4 introduces us to Mr. Carter. He's a 22-year-old guy who arrives in the ED with a life-threatening asthma attack. He can't complete sentences. He's using accessory muscles in his neck to heave his chest open.
That's a bad sign.
Yeah. His respiratory rate is 30 breaths per minute, way above normal, and his peak flow is only 35% of what it should be.
Mr. Carter is on the verge of respiratory failure. Asthma is, at its core, a chronic inflammatory condition. In allergic asthma, it's driven by a hypersensitivity reaction.
What does that mean exactly?
Well, to picture this, imagine an individual with a genetic susceptibility breathes in a trigger, say, cat dander.
Okay.
Their immune system overreacts and creates specific IgE antibodies. These antibodies attach themselves to mast cells embedded in the airway walls, acting like microscopic tripwires.
And when Mr. Carter inhales that allergen again, it hits those tripwires, and the mast cells basically detonate.
Clinically, we call it degranulation, but detonation is accurate. They instantly dump a massive payload of chemical mediators, including histamine and leukotrienes, right into the surrounding tissue.
And what does that do?
This triggers a 3-pronged attack on the airway. First, the smooth muscle wrapped around the bronchial tubes violently contracts, squeezing the airway shut.
That's one.
Second, it causes profound vascular leakage, so the airway walls swell up with fluid.
Okay.
And third, it stimulates goblet cells to pump out thick, sticky mucus.
Muscle spasm, swollen walls, and a flood of mucus. No wonder he's breathing 30 times a minute.
Exactly.
So how do you pull him out of this spiral?
You attack the mechanism. First, blast high-flow oxygen to overcome the hypoxia.
Right.
Second, administer nebulized bronchodilators like salbutamol. Salbutamol is a beta-2 agonist. It chemically forces those convulsing smooth muscles to relax and open the lumen.
But that only treats the symptom, right?
Exactly. Third, he urgently needs systemic corticosteroids. The steroid is the heavy artillery that suppresses the underlying immune explosion, shutting down the swelling and mucus production.
Let's contrast Mr. Carter's reversible asthma with Case 5, Mr. Newman.
Right, the COPD case.
Yeah, he's 65 years old, and he has a 46-pack year smoking history. Just to clarify the math on that for everyone, a pack here means multiplying the packs smoked per day by the years smoked.
So 2 packs a day for 23 years equals 46 pack years.
Exactly. He comes in with a chronic productive cough and progressive breathlessness. He is diagnosed with COPD.
Both asthma and COPD obstruct airflow, but the underlying destruction is entirely different.
How so?
COPD, driven largely by decades of toxic exposure to tobacco smoke, is an umbrella term combining chronic bronchitis and emphysema.
Okay.
The bronchitis causes the endless mucus and coughing, but the emphysema is the physical, irreversible digestion of the lung's architecture.
Here's where it gets really interesting. The physical exam notes that Mr. Newman demonstrates pursed lip breathing. Yes, a classic sign.
He's instinctively exhaling through tightly pursed lips, almost like he's trying to blow a thick milkshake through a flimsy paper straw. Why does his body naturally want to do that?
Because emphysema destroys the lung's elastin fibers. Elastin provides the natural rubber band recoil that holds small airways open when you breathe out.
Oh, I see.
Without elastin, those tiny airways become floppy. When Mr. Newman tries to exhale, the positive pressure in his chest crushes those floppy airways shut, trapping the air deep in his lungs.
So the flimsy paper straw just flattens under suction.
Precisely. By pursing his lips, Mr. Newman restricts the air escaping his mouth. This creates a bottleneck, generating back pressure that travels all the way down into his lungs.
Wow.
Yeah, that internal back pressure literally splints those floppy airways open from the inside, preventing them from collapsing and allowing him to actually empty the trapped air. It's an incredible subconscious survival tactic.
That's amazing. But how does a doctor definitively tell the difference between asthma and COPD on paper? Both patients are wheezing, both have narrowed airways. The dividing line is spirometry.
Spirometry.
Yeah, it's a machine that measures your forced vital capacity, the total amount of air you can blow out, and your FEV1.
PV1.
The amount of air you can forcefully blow out in the very first second.
Think of it like emptying a water bottle, right? The total water inside is your capacity. FEV1 is how much water you can aggressively squeeze out in second number 1.
Exactly.
If your tubes are obstructed, that first second squeeze is going to be incredibly weak.
A perfect analogy. In COPD, that FEV1 is severely reduced, and the ratio of FEV1 to total capacity drops below 70%.
Okay.
But here's the diagnostic key. If you give Mr. Newman, the COPD patient, a strong bronchodilator, those numbers barely budge.
Because his airways are structurally destroyed.
Right. But if you give Mr. Carter, the asthma patient, the same drug, his spirometry drastically improves. The hallmark of asthma is variable, reversible obstruction. COPD is permanent.
Structural damage versus reversible inflammation.
Yeah.
Okay, let's shift gears from airway obstruction to vascular and infectious threats. Yes. Case 15 introduces Miss LaFive. She's 24, complaining of severe pleuritic chest pain, that sharp sandpaper pain when breathing. But the physical exam zeroes in on a swollen, warm, tender right calf. How does a leg problem cause lung pain?
Well, if we connect this to the bigger picture, the cardiovascular system is a closed loop. Miss LaFev is experiencing a pulmonary embolus, or PE.
Okay.
But the crisis didn't originate in her chest. It started in the deep veins of her calf as a deep vein thrombosis, a DVT.
To understand why blood suddenly clots inside a healthy 24-year-old's leg, we rely on Virchow's triad, right?
Yes, Virchow's triad.
Because the body is always performing this high-wire balancing act between bleeding to death from a scratch and turning your entire bloodstream into solid jelly. Virchow's triad outlines the 3 ways that balance tips toward jelly.
Exactly. Factor 1 is hypercoagulability. The blood chemistry shifts, making it stickier, perhaps due to genetics, pregnancy, or certain medications.
And factor 2.
Factor 2 is stasis. Imagine a slow-moving river where silt naturally builds up at the bottom. When blood pools in the legs from long flights or bed rest, it's prone to clotting.
And third factor.
Factor 3 is endothelial damage trauma to the smooth inner lining of the vein, acting like jagged rocks in that river, catching platelets.
So if a patient hits one or more of these triad factors, a solid mass of clotted blood forms in the calf.
Right.
And the terror of a DVT is that a chunk of that jelly breaks off. It becomes a rogue embolus.
It does.
It gets swept up the large veins of the leg, shoots through the inferior vena cava, enters the right atrium of the heart, gets pumped down into the right ventricle, and gets blasted directly into the pulmonary artery heading for the lungs.
And because the lungs' blood vessels branch and get smaller and narrower, that clot inevitably wedges tightly into a vessel.
Barricading blood flow to an entire section of lung tissue.
Exactly. The lung tissue is still inflating with oxygen, but there's no blood arriving to pick it up. The tissue starves, causing acute breathlessness, a drop in oxygen saturation, and that sharp pleuritic pain as the starved tissue inflames the pleura.
Diagnosing a PE is a great lesson in medical logic. The textbook highlights the D-dimer blood test.
Oh, the D-dimer. D-dimers are microscopic protein fragments left over when the body tries to dissolve a clot.
Okay.
The test is highly sensitive, but completely nonspecific, meaning if your D-dimer is high, it doesn't prove you have a PE. It could be elevated by recent surgery, an infection, or pregnancy.
But it is an exceptional rule-out tool, right?
Oh, definitely. If your D-dimer is 0, you can confidently say there is no significant clotting occurring anywhere in the body.
It can't tell you that you have a clot, but it proves that you don't.
Precisely. If it is high, you move to the heavy machinery. A CT pulmonary angiography, injecting contrast dye to physically see the roadblock in the vessels, or a VQ scan.
What's a VQ scan?
The VQ scan looks for a ventilation-perfusion mismatch. V is ventilation, the air going in. Q is perfusion, the blood flow.
Right.
If a segment of the lung lights up with V but has 0 Q, you have a massive dead space. Air is arriving, but blood isn't. That confirms the embolus.
Before we wrap up, we need to touch on case 18, hospital-acquired pneumonia. This is a 72-year-old stroke patient who suddenly develops a fever and severe breathlessness on the recovery ward.
This case perfectly illustrates what happens when the mechanical defenses we discussed earlier are bypassed.
How so?
Community-acquired pneumonia usually involves inhaling ambient airborne bacteria, but a stroke frequently damages the neurological control of the throat, wiping out the gag reflex and causing an unsafe swallow.
So when the patient tries to drink water or eat, the epiglottis fails to close over the trachea. They aspirate.
Yes, food and fluid drop straight down the pipe.
They completely bypass the turbinates and the mucociliary escalator.
Exactly. It dumps massive loads of aggressive bacteria and acidic stomach contents directly into the pristine alveolar space.
And the alveolar macrophages are instantly overwhelmed.
Completely overwhelmed. The resulting inflammatory response is apocalyptic. The lung tissue fills entirely with pus, dead cells, and fluid, creating what's known as lobar consolidation.
Lobar consolidation.
Yeah, the spongy lung tissue literally solidifies into a dense, fleshy mass that shows up as a huge white cloud on an X-ray. Gas exchange drops to 0 in that lobe.
It's a brutal reminder of how mechanical our safety really is. If the trapdoor in your throat glitches, the entire system is at risk.
It really is.
Okay, before we finish, I promised a review exercise to test how much of this textbook you've absorbed.
Sounds fun.
Rather than just reading a dry, multiple-choice question, let's treat this like a clinical thought experiment. Imagine you're the doctor.
Okay, you're the doctor.
A patient comes into your clinic struggling to breathe, their chest sounds tight, they're wheezing loudly, they're distressed. How do you know if you're dealing with asthma or if you're dealing with COPD?
That's the million-dollar question.
What is the single characteristic of their breathlessness that proves their lungs have suffered permanent structural damage rather than just a hyperactive allergic reaction? Give it a second.
Think about what we said about reversibility.
The answer is whether their breathlessness is relentlessly persistent and progressive.
This cuts to the core of the pathology. Asthma symptoms fluctuate wildly. A patient might be terrible at night or around a trigger, but completely normal the next afternoon.
But if it's persistent,
If a patient's breathlessness is persistent, meaning it never truly goes away, and progressive, meaning it steadily worsens month over month, you are looking at the irreversible physical destruction of the lung architecture.
the elastin is gone, the alveoli are digested.
That is COPD.
It all comes back to reversibility versus permanent damage. Now, I want to leave you with a final thought to mull over. We've spent this time marveling at how the respiratory system evolved, this incredibly sophisticated, multi-layered defense matrix. From the mechanical flypaper of the mucociliary escalator to the microscopic cellular garbage trucks patrolling the deep lung.
It's an intricate system optimized over millions of years of evolution to seamlessly handle ambient dust, pollen, and naturally occurring pathogens.
Yet, as we see in diseases like COPD, these exact highly evolved defenses can be completely overwhelmed and actually turned against the body by chronic exposure to modern environmental triggers, whether that's tobacco smoke or heavy industrial pollution.
It's a striking contrast.
It really leaves you wondering, What does the rising global tide of chronic lung diseases tell us about the profound mismatch between our ancient, finely tuned biology and the modern, industrialized air we're forcing it to breathe? Until next time, keep breathing.